Hi, Andrew Penn talking about anti-anxiety medications. In this particular module, we're going to talk about the serotonergic agents used in the treatment of anxiety. So these are going to be SSRIs and some other medications that double, uh, antidepressant agents that double as anti-anxiety medications. And so these are things such as the SNRIs, tricyclic antidepressants, and Boosperone. So I'm going to talk about benzodiazepines in a next section, but right now I want to talk about what's really your long-term strategy, which are the SSRIs and SNRIs. And I'll talk also in a later module about antihistamines. So the SSRIs are definitely useful in the treatment of anxiety. So we see here a comparison between some of the SSRIs, and these are effect sizes. So a 0.36, it's a moderate effect size. It's not huge, but it's certainly better than nothing. And so you see SSRIs, importantly here, SSRIs and benzodiazepines have similar equivalency. Venlafaxine as a SNRI may be a little bit more effective, and it goes on to some other medications, or hydroxyzine and pregabalin. So the idea here is that by increasing serotonergic tone, you may actually reduce noradrenergic firing in the locus ceruleus, in areas of the brain that are responsible for generating anxiety that we talked about in an earlier module. So this gives you some wide utility in multiple anxiety symptom clusters. And as I mentioned before, these often overlap. So that's good news. These treatments are able to cover multiple bases. And then there is also data for other drug classes such as imipramine as a tricyclic antidepressant and venlafaxine as a SNRI. So some general points with the SSRIs, which you'll probably now be familiar with from treating depression. And while they're often referred to as antidepressants, you can interchangeably use the term anti-anxiety medications with them. And we often use higher doses than we do in depression. So particularly with OCD, we often need much higher doses. It was not uncommon for me to have OCD patients on 80 milligrams of fluoxetine, or sometimes I would go off-label, go to 100, 120 milligrams if we were able to get good benefits and the patient was tolerating it well. But the downside is that SSRIs can cause that kind of akathenic restlessness, the activation, especially in the first week or two of treatment. And people with anxiety, because of that sensitivity to interoceptive sensation, anxiety, may be more sensitive to that. So what you might want to do with people who you're targeting with an SSRI for their anxiety is to go slow and start low. And the good news is, because anxiety sadly often goes along with depression, by using an SSRI, you're covering both sets of problems. Now, here's a grid that just sort of outlines and refreshes your memory about the different medications in this class. So fluoxetine, paroxetine, citalopram, sertraline, fluvoxamine, which many people have not heard of. It's called Luvox, and it has an OCD indication from the FDA. It's a little bit of an odd duck, but it's an SSRI. And then escitalopram, or Lexapro. Now you can see to the right there, here's all the FDA indications for it. Now what this means was that the drug company that was developing it, so let's say sertraline, which was developed by Pfizer, I believe, they did a lot of work. They went and they did studies on OCD, they did studies on panic disorder, studies on social anxiety disorder and PTSD, and they were able to get FDA indications for all of those drugs. But my experience in clinical practice is that this is a class effect, which is to say that SSRIs, regardless of their FDA indication, will work for anxiety disorders across the board, and that you'll see that very commonly in clinical practice. SNRIs and some of the atypical antidepressants, such as mirtazapine, also have utility in the treatment of anxiety. So venlafaxine, which is Effexor, duloxetine, Cymbalta. And so that, whereas some of the atypical ones don't have a labeled use for it, they are commonly used, particularly mirtazapine. We've seen a lot of use of mirtazapine in treatment of anxiety and gotten good benefit from it, although that is an off-label use. And like all off-label treatments, it's worth having a brief conversation with your patient and then documenting that conversation in your notes. Now, these are, again, going over the atypical antidepressants, which have some utility in certain cases. So nifazodone is rarely used these days, which I think is kind of unfortunate. It had the brand name of Serotonergic, and this is a cousin of mirtazapine and trazodone. And one of the things I like about it is that it doesn't cause sexual dysfunction. And that's rare in antidepressants because really, other than mirtazapine, we have bupropion, and bupropion doesn't work that well with anxiety. So um, all the other treatments, SSRIs, SNRIs, can certainly cause sexual dysfunction. Now, the reason why nifazodone fell out of favor is because there were some case reports of liver failure associated with it. And that got the FDA to put a black box warning on it, and people pretty much stopped prescribing it. But it is one of those good, deep in your back pocket kind of medications to know about. Mirtazapine probably is definitely more used and is a little safer to use too. Now, it's great for sleep, as we talked about in the insomnia module, and it's usually well tolerated for people that have GI issues with antidepressants because it actually blocks the serotonin 3 receptor, which is the same thing that Zofran does. Now, the downside is that sedation can be too much of a good thing, and weight gain can be a real problem. And trazodone, we don't normally see treating for anxiety. That's usually used for sleep, but you could potentially use that if the person could actually tolerate the sedation. Tricyclic antidepressants, that was the mainstay of psychiatry before SSRIs, so before about 1987 when those started coming out. So there's a couple that are worth highlighting here for anxiety. Imipramine is one drug, and then clomipramine is sort of has a little niche for being the gold standard for OCD treatment. And the reason for that is it is the most serotonergic of all the tricyclics. So if you recall from the antidepressant lecture, tricyclics are SNRIs, essentially. They inhibit serotonin and norepinephrine. Now, they're not all the same in their degree of reuptake inhibition of each of those neurotransmitters. So clomipramine has very little activity on norepinephrine, but is enormously inhibiting to the serotonin transporter. So that is considered because it's thought that OCD requires a lot of increased serotonin in order to treat it, that this is still considered kind of the gold standard. But with all tricyclics, you want to have that same sensibility about getting an EKG, not using them in people that have arrhythmias, and being careful not to add them to other anticholinergic medications like ditropan, for example. Boosperone is sort of another curious outlier. So this is really kind of in a class by itself. It's a partial agonist of the serotonin 1A receptor. It does not work on GABA. And it has an indication for generalized anxiety disorder. It's not a great drug for people that have panic disorder. It doesn't seem to work very well for that. And it's certainly not a PRN medication. So you need to be taking it on a regular basis in order for it to work. And in my experience, I found that well, people usually start at 5 to 10 milligrams twice a day. You typically need to get up to a daily dose of somewhere around 45 to 60 milligrams a day in order to get much benefit out of Boosperone. And it is also, you may remember this drug as an augmenting agent in treatment-resistant depression. So, I think the impatience that a lot of patients have with this and clinicians have with it lead them to believe that it doesn't work. It's not the world's most powerful medication, I'll be honest with you, but it certainly has some utility. And it may also be useful in reversing the sexual dysfunction from SSRIs. And this might be something you feel more comfortable using in an older patient for whom falls might be a risk. So in summary, SSRIs are really your workhorse for anxiety treatment, but they need time to work. And there are other medications in this group of antidepressants, such as SNRIs and tricyclics, that can be useful. And then Boosperone is that outlier serotonin 1A partial agonist that has an indication for GAD if it's given over a long enough period of time. Thank you for your attention.